So I'd like to show you how to solve a relatively straightforward acid-base problem using the 6-step method. So this is a patient who is found down and brought into the emergency room. The patient's pH is 7.25. The PCO2 is 24. Bicarb 15. Sodium of 140. Chloride 100. And the bicarb, as I stated, is 15. When we look at these particular problems, the first issue is the clinical picture. In this particular case, the patient was found down. We would hypothesize that maybe the patient had a low blood pressure and may have been down for a period of time, perhaps has a low perfusion that may lead to a lactic acidosis. Lactic acid production leading to an acidosis. The next step is our pH. Is our pH above or below 7.4? And in this particular case, it's below 7.4. And so we have an acidemia, which is what we suspected according to our clinical information. The next step is looking at the primary acid-base problem. And the way we do this is we look at the relationship between the pH the bicarb relative to the PCO2. Let's give ourselves a little bit of room here. In this particular case, we know our pH is low. It's 7.25. And if we have a low pH, we are going to have either an increase in PCO2 or a decrease in bicarb. In this particular case, we have a decrease in bicarb. Our bicarb is 15. And because we have a decrease in bicarb, the relationship makes sense. The only other way we could have a decrease in pH is if we have an increase in PCO2. And in this particular case, if we look at our pH is low, our PCO2 is low, and our bicarb is low. So the only thing that makes sense within this particular formula is that the bicarb has to be low for the pH to be low. So our primary acid-base problem in this case is a metabolic acidosis. Why? We know we have an acidosis because of the low pH, and we know we have a low bicarb. So a low bicarb of 15 in the setting of a low pH of 7.25 indicates that we have a metabolic acidosis. That's our primary acid-base disturbance. The next step is going to be figuring out what the compensation is. So what's our compensation? Remember, the body compensates for an acidosis, a metabolic acidosis, using the respiratory system. And so we are going to compensate in terms of increasing our respiratory rate or increasing our respiratory rate or increasing our tidal volume. So the depth of breathing and the rate of breathing is going to increase. Compensation formula allows us to figure out what our expected PCO2 will be. And that's the Winter's formula, and we use the Winter's formula for metabolic acidosis. Each acid-base disturbance has a separate formula in terms of compensation. This is the Winter's formula, so our expected PCO2 is 1.5 times the patient's bicarb plus 8 plus or minus 2. These formulas are not necessarily needed to be memorized. However, you we'll use the Winters formula so often that you probably will remember it. So if we calculate 1.5 times the bicarb, and remember in this particular case, the bicarb is 15, our expected PCO2 then will be 30.5 plus or minus 2. Okay? Our measured PCO2, if we recall, is 24. Our expected PCO2 is in the range of, say, 28 to 32. In this particular case, our compensation for a metabolic acidosis, we would expect our PCO2 to be in this particular range. It is this. And so our PCO2 is less. Our measured PCO2 is less than expected. So you ask yourself, what is a situation where the PCO2 is less than normal? So less than expected. And PCO2 less than expected will be in a situation where you have a respiratory alkalosis. So in this particular case, we have a metabolic acidosis, we have compensation, and we have an additional respiratory alkalosis. Our compensation would expect, PCO2 would expect to be in the 28 to 32 range. If the PCO2 measured is 30, and the expected PCO2 is 28 to 32, then all we have is compensation for the metabolic acidosis. But because our PCO2 is less than what we expect, we are actively blowing off PCO2 for a particular reason, and we have a respiratory alkalosis. The next step is our anion gap. The anion gap, in this particular case, the sodium is 140, the chloride is 100, and our bicarb is 15. This anion gap is 25, which by definition is a high anion gap. High anion gap. Metabolic acidosis. So we know that the metabolic acidosis that we saw earlier here is a high anion gap metabolic acidosis. The final step, step 6, is to calculate the delta-delta. The delta-delta is the change in anion gap over the change in bicarb. In general, we expect the anion gap to be in the range of 1 to 2. So what that says is that for every increase in anion gap, one increase in anion gap, you'd expect the bicarb to go down by approximately 1. And in this particular case, we will see that our anion gap elevation is much higher than our, well, say that another way. Let's do the formula. So our delta anion gap is 25, that's our measured anion gap, less 10, which is our normal quote-unquote anion gap. Change in bicarb is the normal bicarb, which is 24, less what our bicarb is, which is 15. If we do this particular formula, what we get is 15 divided by 9, which equals 1.67. So from this delta anion gap, delta bicarb relationship, we know we're in the normal range, delta delta, of 1 to 2. So and so we can stop. So in this particular case, what we have is we have a high anion gap metabolic acidosis in addition to a respiratory alkalosis. High anion gap metabolic acidosis based on the fact that our anion gap was 25. A respiratory alkalosis based on the fact that our expected PCO2 was 28 to 32 based on the Winters formula, and our actual PCO2 was 24.